So do we have any questions from the participants?
Yes, sir.
Much, not yet. Okay, don't put your questions at the end of the chat. When I'm closing the discussion, if I get a question, don't think that I will answer. Okay. You need to be ready with your questions. You might have watched the previous videos before, and you should be ready to fire your questions. Okay. And the next thing is demonstration time. Okay. So what we have here, we should utilize and go ahead with the masterclass. Okay. Right. Girish sir, have any questions?
Yes. No,
Yes,
sir.
No. Yes, ma'am.
Yes, sir. Actually, the main thing which in my one patient, banding, forward banding, okay. Coming back, like as you were showing that if there is a myofascial problem, the spasm is there, then patient will coming back, or he will not allow you to touch that place. So he keeps his hand on that place. So that time we have to give that if post isometric contraction we can give reciprocal inhibition
Yeah.
for spasm. Yes, spasm. So that is the today I have seen that we have to just press on the sternum also, then we can give the reciprocal inhibition. And this type of patient, if they are not allowing the area of the spasm, so simultaneously can we give the myofascial release, and then we can add the motor control retraining for making the facial FMR also. So for that we can checking the when we are doing the physical examination, simultaneously we can give it in the positioning of coming back, returning back.
Yeah, anything you can do. See, facial-muscular release involves motor control, myofascial, okay,
Yes, sir.
and reciprocal inhibition. All three together also can be given. Okay.
Okay.
So, and the direction of facial glide, if it is returning, means inferior glide should be given from the painful region to inferior. If it is forward bending, means from the painful region to superior. Okay. Because the direction of the movement and the direction of the facial glide should be together. Okay. Same. This one.
Right. So, and this is that I think it was very clear that the orthomyoneuromanual therapy with this physical examination which you have shown is very, I think, will give the clear view. And the one thing which really that we were missing, that we were not stabilizing the sacrum by checking the lumbar spine. That's why there is a misconception is coming that either the lumbar spine is in dysfunction or a pelvis is dysfunction. So today I think it's very clear now that we have always keep our hand on sacrum, stabilize that sacrum, then we can give the physical examination of lumbar spine, so that there is a not misconception will come. So it's very, I think this
See, this is the thing, problem oriented physical examination. So I do flexion itself, there itself I treat.
Yes,
okay,
sir.
immediately.
Yes, sir.
Mobilization has to be given, correct. Motor control has to be given, correct. FMR, facial-muscular release has to be given, correct. You want neural, that also can be given. Okay. Neck flexion with knee flexion, neck extension with knee extension. It will become a slider. Okay, squatting with the neck flexion. Okay, it will become a slider. After that, you can bend forward. Okay, so every treatment goes parallelly. Okay, so that it saves a lot of time in the clinical practice when a lot of patients are there, and at the same time, it keeps your physical examination or your reasoning to be open. Okay. And individualizing to every patient. Diagnosis may be spondylosis, but patients have problem in bending. Some patients may have problem in standing. Okay, so if it is only standing, I did not check the movement. In the standing itself, I can give the NAGs, the natural apophyseal glides. Okay, so postural, at rest only I'm giving the mobilization. The same maintenance technique I'm giving in standing. Okay, that becomes the natural apophyseal glides of malignant. So that is a totally, directly you treat the functional problem. If the patient is not allowing that, then you see what is the cause. Okay? It may be that it is very fixed. Okay, it is not allowing the movement. Okay, you need a more precise mobilization. Then do the differentiation, segmental, which spinous process is opening or not opening. Because you know that flexion means spinous process has to open. Okay. So this much opening has to be there when you are palpating. And during extension means the spinous process will come closer. Okay. And if the other segment is coming closer, this is coming closer, but this is not coming closer, I know that this segment is not extending. Okay. Other segments is opening, this is opening, this is not opening. I know that this segment is not flexing. So then specific pressure here will create the flexion. Okay. Or I do this pressure, distal vertebra, it will create the extension. Okay. So the same thing can be in a combined position also. I can add lateral flexion or rotation to the flexion and then give the pressure on the spinous process. Okay. So there is limitless probabilities because patient's clinical presentation will be very dynamic. Today, what is the presentation? Tomorrow, another presentation may be there. Okay. Diagnosis does not change. But what changes is the dysfunction that changes. Okay. The responses to testing. Okay. That will be different every day. So that is why keep it open and make sure that at any direction you can just modify, differentiate, and then see. Okay. I have not shown the compression and the distraction. Okay. Because lumbar spine compression distraction in the standing position is very tough. Okay. You can check with accessory movements for the articular. Okay. The segmental movements you can give on the spine or on the facet. Okay. You can check the articular component. Okay. But don't try to compress the this one. But in sitting, you can do that. Okay. Sitting forward bending, you can do the compression or do the distraction. You can also do that same in the prone position. Okay. But that distractions I will show mostly for the disc, because if you see compression, if I am doing means which structure is influencing. It is only the disc which is getting influenced. Okay. I have made this, this is again for the disc above I have stuck. Okay. So what's important here is to know that functional. Okay. So functional position. If it is claudication, after walking the symptom is coming, there's no point in assessing all this. Okay. What's important to assess the walking only. Okay. And see that whether walking is any deviation is there in the lower limbs. Because if lower limb leg length discrepancies are there, lumbar spine problem symptoms can come as a non-specific low back pain, not necessarily stenosis. Okay. So in stenosis, you need flexion. When the claudication has come, that time, that moment, if you give a flexion, it will relieve the symptoms. Okay. So that will be the differentiation for that. So every spectrum of clinical presentation will indicate that direction of progression. Got one question from Dr. Jyoti. Okay. Can we do lumbar spine examination in horse riding position if any standing issue? That is what I told by sitting position. Okay. Why it is called as horse riding position? Where will I find the horse here? Okay. So I cannot make the patient to sit on a horse and then I stand above the horse and then examine. Okay. Don't think about horse riding position. Sitting position means horse riding. What horse riding or car driving? Whatever is there. Sitting is sitting. Okay. You want to keep the legs abducted, you keep it abducted. Okay. But remember that when you are keeping it in abducted position, you are relaxing the iliotibial band. Okay. So the dynamics of that position you should see. Okay. Normal sitting, if I am sitting like this and I am forward bending. Okay. I'm sitting like this and forward bending versus keeping the knees together and then forward bending. It's totally different. Okay. And the same way, if I'm keeping abducted and then forward bending, okay, definitely iliotibial band is relaxed. Okay. And ITB is important for the pelvis. Okay. So in what situation you will do this? You will check the upper lumbar. Okay. That means L1 to L3. You can check in this sitting position. Not the L4, 5, S1. Okay. Because it is already flexed position. It is there. Okay. It's not moving. Even in sitting, if I am rotating, it is thoracic spine rotation, not the lumbar spine rotation. Okay. Whereas in standing means it is always lumbar spine rotation. So, sitting if you are using, it is only when patient is telling problem with sitting, you will use the sitting. Okay. Patient is telling problem with standing, then you use the standing. Okay. Problem will matching. Make sure that the subject goes to sitting the same day. Okay. Only advice what you will give is monitor the duration of sitting. Okay, if at all the pain alerts, you see that what are the measures which you can relieve, whether it is the motor control, okay, or whether it is the self snacks, okay, various techniques, okay. So you need to modify that activity modification. So once in sitting time, keep the legs up, okay, or just rotate, okay, mid range, don't give thrust, okay. So this kind of mobility will rehydrate the disc, okay. So the subject can get better just by, and they can sit for longer periods of time. They forget these things and they keep on sitting. Then after work, when they get up, they'll be like, "Amma." Okay. So the activity monitoring and activity pacing is part of the what is called as the home program. Okay, so which you have to give. If the patient tells pain in sitting, if pain not there in sitting, don't bother about it. Okay, right?